And we have, this is fairly new, actually it's been there for quite some time. This is a society which is trying to give us better guidelines for the use of micropulse lasers in various retinal pathologies, and we have a wonderful line of speakers here. We'll dive straight away into it. It's my pleasure to invite Dr. Lite Wu from Costa Rica, who's going to first give us an introduction. He's the president of our SOLS Society, and has done a tremendous amount of work. He's going to first give us some background guidelines about subthreshold micropulse laser, and then he's going to talk to us about subthreshold laser for central serous chorioretinopathy. So it's a pleasure to ask Dr. Lite to start off. Yes.
Mike. I have my slides and this computer is off, you know.
Right. Tech team, can you have his computer up? Yeah.
No.
This is the previous. So in the meantime, of course, I am Dr. Anand Rajendran from Arvind Eye Hospital, Chennai. I think the retina service here. And with me is also Dr. Jay Chablani, who was at LV Prasad earlier and is now at Pittsburgh, senior consultant there, avid researcher, and Dr. Martin Brellan from Hong Kong. And all of us have a real passion for this particular laser modality. And given the fact that in many places photodynamic therapy is not available. It's
wrong talk.
Oh, this is not my. Ye mera hai bhai. Inka hai. Dr. Lite. You have two. Both are continuous in the same slides?
Yes, that one. That one. Yeah. No.
The second one.
No, the last one.
Oh, the last one. Sorry. Last one first.
Okay.
All right. Good. Full screen laga lijiye.
I do not have anything here.
Is it on that screen? Which screen have you put it up?
You don't remember your slides?
Huh?
You don't remember your slides?
No, I can see it here.
No,
but,
he's not seeing it there.
You know, but I cannot.
Or
Yeah.
can we move it here on this side?
Let them figure it out.
Actually your slides are seen here.
Maybe if you can come here. Yeah. All right. Some teething trouble. All right.
So thank you, Anand. So I just want to ask of the audience, who's familiar with the subthreshold macular laser? Raise their hands, or is this just the first time? Okay. So this is actually very basic. These are my disclosures. Of note, I serve as a consultant for Lumibird, who is one of the manufacturers of the laser companies. So we're going to be talking and making the differentiation between conventional laser photocoagulation, and it causes significant chororetinal damage even when properly performed. And we can decrease the damage by changing the laser parameters and the clinical endpoints. So this is the reason why the micropulse or subthreshold laser was developed, to try to eliminate this iatrogenic damage from conventional macular photocoagulation. So you can see here, this patient was treated with actual parameters from the ETDRS. But years later, many years later, the patient has no macular edema, but technically he's kind of blind, because you can see that with time the scars sort of expand. So what's in the name? So when we talk about conventional macular photocoagulation, we're referring to continuous wave photocoagulation. That means that when you press down the pedal, and remember there's a time and also the power. Once you press it down, then you're going to deliver the power for the entire time. The subthreshold means that there's no visible reaction while performing the laser. Micropulse, the name micropulse is a patented name that actually is by Iridex, and before then it was used very openly by all the other companies, but then Iridex started enforcing their patents, so Other companies had to come up with other names. So for instance, here the Quantel people use it subliminal. And the idea is to deliver energy in pulses so no damage to Brooks membrane is going to happen. Both of these are subthreshold modalities of laser treatment, but not all subthreshold modalities are the same as micropulse or subliminal. So here's an illustration, a cartoon that of what conventional photocoagulation is. So you see here that when you press the foot pedal, the power goes up to whatever you determine it, and it stays on for the entire pulse, the duration of the pulse. So one of the things that you can do, and you have to remember to lower the damage, is you can actually reduce the spot size and adjust power to reduce the irradiation. Just remember that the power is a function of you have to remember that in a circle, the power delivered is more when the spot size is smaller. So you also have to reduce the power, but you have to do it by 4, because remember, it's a circle, so it's pi r square, the relationship. So the retinal temperature rise is proportional to the irradiation. Remember that the target is the RPE, and what we want to do is try to stay within the RPE. If we stay with the time too long, then we're going to have that beam of energy that's going to be expanding in the horizontal direction and also in the vertical direction. So that's why that we want to reduce the times. So I've shown you a couple ways that you can reduce the iatrogenic things when you're doing conventional laser photocoagulation. One of them is to reduce the retinal irradiation, and the other is reduce the pulse duration. So let me introduce to you now the term of the micropulse or subliminal, where the idea is that here you have the entire duration of the pulse, but what we've done is that we only select a portion of that time where the laser is firing, and the rest of the time the laser is off. So this will allow you to actually concentrate on the RPE, and the heat will not rise up, and then you can avoid having that lateral expansion and the vertical expansion of the heat wave. Remember that for this is a macular treatment. So we're not talking about doing PRP with micropulse or anything like that. So the idea is just to treat the macula because we want to avoid iatrogenic damage to the macular area. The ideal macular laser, in my opinion, is that it should be micropulse or subliminal. The wavelength is important. We prefer the yellow, and also have the multi-spot technology or have the patterns. And also it has to have the ability to have the low duty cycle. So again, subthreshold, no visible reaction while performing the laser, and subliminal is that the energy delivers in pulses, so there is no damage to Brooks membrane. So again, here you can see that we choose the power, and the power goes off, and the rest of the cycle, the laser is not firing, so that allows the tissue to cool down and do not have the iatrogenic problem. Duty cycle, again, is just the percentage of time that the laser is firing in relationship to the time where you've chosen the pulse. So a 5% duty cycle means that 5% of the time the laser is firing, but 95% of the time the laser is not firing, so you have time for it to cool off. So does it matter the wavelength? And you have to remember, there are several wavelengths that we can use here, as noted here. And the 577 is particularly good for macular work, because remember that one of the main tissues that absorbs the heat is the oxyhemoglobin and the melanin. The melanin is concentrated. Here you can see the absorption curves, and the yellow laser has a good absorption curve. This is in the RPE. But if you want to treat the the vascular structures, you can see here is a peak here, and you can also here get the most. And the most important thing here, you can see the extension curve for xanthophyll. And the xanthophyll, remember, is a pigment that is in the macular area. You do not want that to be absorbing. For instance, here the green, you can create iatrogenic damage for that. You can see the yellow here is far to the right, and there's really no absorption there. So 577 also provides greater transmittance through some corneal and lenticular opacities. There's no absorption by the macular pigments, rendering much safer to use in the macular area. And in patients with light or irregular fundus pigmentations, provides a more uniform effect. So yes, the wavelength matters, and I show you that the yellow is perhaps better. In addition, it allows to titrate power directly under the subliminal mode that allows to reach a visible endpoint. So there are two schools of thought. One is that you can use fixed powers to treat in the micropulse mode, whereas others, like myself and the rest of the panel here, believe that it's important to titrate because not everybody's pigmentation is the same. So a Caucasian patient probably is not the same as an African patient. Where there's more pigment, you probably require less power because there's more absorption. And in the past, when we had the 810 nanometer laser, for instance, it was not possible to really titrate power directly in the micropulse mode. You had to do it under conventional photocoagulation mode, and sometimes accidents occur because you chose the power, but you forgot to switch back to the micropulse mode, and you're treating in the macula, and you go, oops, and that can be a problem. The multi-spot is also important. So multi-spot refers to the patterns. So you can get a step on the pedal, and then you get a pattern of burns. And the importance of this is because since the burns are invisible, we really need to use this to treat the more area more efficiently, because the most common cause of treatment failure is under-treatment. And typically in all our cases, what we recommend is to use the high-density treatment. High-density means that the burns are contiguous one to the other, and we can just treat them with the pattern. You can imagine if you only had like monospots and those burns are invisible, how can you really treat the whole area and make sure that you're treating uniformly when they are invisible, right? So that's why the pattern is important. And this is an example. The Brazilians did a study here where they did high density, normal density, and conventional modified ETDRS. And here you can see that for the most part, the best results were in people where there was a high density. Let me skip this. And finally, talking about the duty cycle. In the past, because of the technology, the first one was 15% duty cycle, then they came down to 10%, and now down to 5%. And the reason is that in animal studies, this is a poster that Victor Chong presented in ARVO many years ago. You can see that the lowest iatrogenic damage that occurred in the rabbits was with the 5% duty cycle when compared to other duty cycles. So it's just safer. Okay. All right. So the idea is whenever we have the patient here, we titrate, and the way of titrating this is that you go outside the arcades and then you start shooting the laser under the micropulse mode until you get a barely visible burn, and then you cut down the power to 50%. This is kind of our recommendation. Some people say a third, 50%. Nobody really knows exactly what, but that's the idea, to keep it in the safe side. And also, when we treat DME, we are not really aiming to the areas of leakage per se, like we use the fluorescein angiogram as a guide. We mostly just use the OCT and try to treat the thickened areas. So in summary, the key characteristics of an ideal laser for macular work should be that it has the capacity to work under the subliminal or micropulse mode, that it has the capacity of the patterns with the multi-spots, the yellow wavelength, and the ability to have a low duty cycle. Thank you very much for your attention. Okay. And the next talk is also on mine, the next one.
Does anybody have any quick questions about the mode, the manner of treatment, or anything about the way before Dr. Lite moves on? No? Then we go on.
So now I'm going to be talking about micropulse laser as the first line of treatment for central serous chorioretinopathy. So the background of this, again, my disclosures, the background of this is that for central serous chorioretinopathy, for the longest time we've used PDT to treat this, okay? So CSCR is characterized by choroidal hyperpermeability, PED, and retinal neurosensory detachments. In most patients, there is spontaneous resolution, but in some patients, the disease becomes chronic with ensuing visual loss. And for these patients with the chronic, PDT with verteporfin has been used to treat these eyes. And that's what we used to do in Latin America until maybe 2011 or 12, when Visudyne disappeared from the market. And even now, we do not have Visudyne available. So that was part of the needs that why we decided to explore micropulse or subliminal laser. So verteporfin PDT has adverse effects that include transient reduction of macular function, RPE atrophy, and choroidal non-perfusion, and that can lead to secondary CMV as well. So in order to reduce these complications, our friends from Taiwan decided, what will happen if we have to dose or we have to fluence with these eyes with CSCR? And they showed in this publication that both PDT protocols were effective in improving best-corrected visual acuity and eliminating subretinal fluid. However, choroidal hyperperfusion still occurred in a significant number of patients using either of these protocols. So you already saw this. So our group in Latin America decided to compare our experience with the micropulse laser compared to half-dose PDT, and we follow these patients for 12 months. So this was a retrospective comparative study of 92 eyes that were treated with yellow subthreshold laser, and some were treated with half-dose PDT. And our definition of chronic CSCR was defined as persistent subretinal fluid for 6 or more months. And this is pretty much what we did with the subthreshold laser, a duty cycle of 5%, pulse duration of 200 milliseconds, and we use high density, no spacing between burns, and the spot size varied from 100 to 200 microns. We did power titration, as I explained to you earlier, and the PDT was half the dose, therefore 3 milligrams per meter square Visudyne, 15-minute infusion, and the laser activation for 83 seconds. And notice the spot size that ranged from 400 to 2,000 microns. These are the baseline characteristics, and you can see here the micropulse group versus the PDT, and you can see here really that they were pretty much match in baseline characteristics with regard to age, the duration of symptoms, the central macular thickness, the subfoveal choroidal thickness, and the starting visual acuity. These are the results at 12 months, and you can see that in terms of the micropulse laser, there was an improvement in the macular thickness, also in the best corrected visual acuity actually had an improvement, and in comparison, the PDT group also had an improvement in the anatomy, but the visual acuity kind of remained stable. If we look at the visual acuity in more detail, you can see the distribution of visual acuities were better in the subthreshold laser compared to the PDT group. Here you can see this graphically. So let me remind you, this is the best corrected visual acuity in logmar scale. So again, the higher the logmar, the worse the visual acuity. And you can see here the PDT group, pretty much a flat line, whereas the micropulse was, you could see here statistically significant differences from the baseline or an improvement in best corrected visual acuity with the micropulse laser. In terms of the anatomic outcomes, PDT was a little bit better numerically compared to subthreshold laser in terms of the reduction in central macular thickness. Sorry, I'm not really a PC user. I'm more a Mac person, but okay. And in terms of the recurrences, you can see here that they were not really that different. Number of treatments, numerically there apparently more retreatments were needed with the micropulse laser than the PDT. In terms of complications in the laser group, none. One eye in the PDT group developed a CNV that was treated with 3 intravitreal injections of bevacizumab. And this is an example of pre-treatment with the micropulse laser. And this is post. So you can see that the fluid has gone away. And this is a pre-PDT case here, the images, and post-PDT, also an improvement in visual acuity. So how does our results compare with the literature? And in general, they're very similar to other series in the literature. So this is another study from the folks in Germany, and their results are very similar to ours. And this is another prospective study that we looked at just patients that were treated with the yellow laser, and we can see that there was this SRF reabsorption up to 70%, but it took maybe 6 months of more. And the effect is not as high in terms of reducing the choroidal thickness in these eyes. This is another study from Turkey, and again, you can see that the results from the micropulse laser and the half-dose PDT were also very comparable between the two. This is another prospective trial from China, and you can see that there was a better resolution in SRF, but the gains in best corrected visual acuity were really non-inferior one to the other. And this is the PLACE study, which is a randomized clinical trial that has, because its publication in a high-impact journal like ophthalmology, has sort of said that PDT with verteporphyrin is better. So they looked at that. They had the 810 nanometer laser, and they used fixed parameters like you see here in the slide, and they said we did high density. However, if you look into the details, and the results showed that the half-dose PDT was superior to the micropulse laser in terms of the functional improvements and complete resolution of the subretinal fluid. But the big but is the 810 nanometer laser does not have patterns, okay? So you can imagine, and they said they did like hundreds of spots for each of these eyes. So if you have hundreds of eyes and they say, oh yeah, we did spots one next to the other and everything like that, and they're invisible, I think they really undertreated their patients in the micropulse mode. So we wrote a letter to the editor here stating precisely that. And so they stated, yeah, the laser spots were positioned adjacent to each other in a non-overlapping fashion, and no multi-spot pattern scan was used. So this confirms my suspicion that indeed I think that these eyes in the PLACE trial were really undertreated. This is work by Martin here, who's here, And they did another prospective randomized clinical trial where they compare half-dose PDT and the yellow subthreshold micropulse laser. And you can see that at 1 year, you can see that pretty much again, the PDT group apparently it's better at drying the macula. And it had a quicker resolution of SRF. But in the end, in terms of vision, both the PDT and the yellow micropulse laser are viable options for chronic CSCR. So let me emphasize again that, you know, in many parts of the world, there is no Visidyne available. So, you know, to say, here our colleagues from Europe saying, oh no, you cannot do micropulse laser because we got Visidyne. That's not true. we have not, even if I wanted to do it, I cannot get Visidyne. So this is a meta-analysis that was recently published in Survey of Ophthalmology and compared the efficacy of different treatments for CSCR. And look, they got 11 RCTs of over 450 eyes. And it says that both PDT and the micropulse laser were superior to the control for subretinal fluid resolution. The micropulse laser was superior to the control for improving best-corrected visual acuity, and the PDT was superior to micropulse laser for improving the choroidal retinal thickness, and the PDT and micropulse were best-ranked treatments for chronic CSCR. So don't discount the use of micropulse laser, particularly if you do not have PDT available in your area. So in conclusion, both half-dose PDT and yellow subthreshold laser are effective in restoring the macular anatomy in eyes with chronic CSCR, but it appears that yellow micropulse laser may have a more beneficial effect in visual acuity than half-dose PDT. Thank you very much for your attention.
Thank you, Lita, an excellent and a very elaborate talk for a pathology that we are, in this part of the world, really having trouble treating because of the lack of, as he said, Visidyne. Does anybody have any questions? Yes, please. Mike, can you please pass the mic?
I'm Vishwanath from Hyderabad, Pushpagiri Institute. Do you have any subgroup analysis of the site of the leakage, subfoveal, juxtafoveal, extrafoveal comparison?
No, the numbers are really too small to really do that. You know, even in Martin's group, they only had like 30 plus eyes per group, and you know, you can't really do subgroup analysis by that. You know.
Whatever you studied, what was the percentage of them in the? They were all.
I'm sorry.
The treated patients. What was the site of leakage? Majority of them.
So it was widespread because these are chronic cases. They had fluid for more than 6 months. You know, it was not really focal leaks that we know that we can treat them with a conventional laser. You know.
So just to clarify, with micropulse yellow laser, you can paint the fovea, and that also repeatedly over repeated visits. So that is one thing where, you know, that's another, you know, USP of this particular treatment modality.
Yeah,
Thank you.
We have published a lot on subfoveal leakage, particularly because one of the biggest fear, and we do see patients getting referred for subfoveal or juxtafoveal leakage because they are not being treated by anybody. So and I have published in both PD group as well as in micropulse. But as Anand mentioned, that the benefit of doing micropulse laser is that there is no structural damage, which again we published even in the long term, there is no structural damage. We can repeat the laser. So I think that's why we all believe that micropulse is a much safer laser even for the subfoveal leaks.
Yeah. And as a corollary, we would also encourage that users of micropulse, please convince yourself by doing autofluorescence at baseline as well as in follow-up. So you can convince yourself that there is no real, if you follow the guidelines and the parameters that we are suggesting from our group, you will also find, we expect that there won't be any signature, not just on autofluorescence, but also on microperimetry. If you do microperimetry, you will find probably that scotoma from CSR reducing, and there's no real risk of the, for example, PDT or ablative laser induced damage. Yeah. Martin, would you like
Thank
to add
you.
something?
Thank you.
No, other than that, in the case sharing at the end of the session, I'll highlight some of those points, particularly on the microperimetry aspect, which
Yeah.
shows a really good improvement in overall threshold sensitivity of the macula
Sure.
after subthreshold laser.
Sure. Just go ahead.
Okay, I have a question about how the parameter change if you find that your patient has under treatment. Like you say that in under treatment, how you
So-
change the parameter after
So,
that.
no, it's not really changing the parameter. It's making sure that your burns are contiguous one to the other. So really there's no spacing between the burns. Okay? So that is what we refer to under treatment because, again, like in the PLACE trial, they did not have any patterns, right? So if you don't have any patterns, you have to visually remember, okay, I put a burn here, and this is monospots, so the next one I have to put right here, but it's invisible, so you cannot see. So that's why I say that that is a problem with their protocol.
Yes, and as he mentioned, one of the reasons why people are doubting the efficacy is because of undertreatment. So this would, as he suggests, yeah. Okay.
So, do you do angiography prior to treatment every time? Or
For central serous, yes, I like to do some type of
FA and
angiography.
ICG both?
Yeah, depending on what we can get. Sometimes the patient cannot afford both, and we just pick one or the other. I try to use ICG better because it gives you more the hyper permeability areas, and those are the areas that you want to treat.
Okay, and if you are repeating, how frequently can we repeat, or how earlier can we know whether it is working or not?
So normally, I bring these patients back in about a month, month and a half, and you can see from the OCT whether or not it's getting better. If it's getting better, then I keep on following until you get the best effect. But if nothing happens after a month and a half, usually by 2 months I repeat it. Because like Jay said, there's really no reason not to do it because you don't really see any damage, to the RPM.
And thank you, Lete.
Okay. Yeah.
I think we'll move on. Next, I'll be inviting myself to speak on subthreshold laser for diabetic macular edema. Take it. So, thank you. So I'll be talking to you about micropulse subthreshold laser and diabetic macular edema. So I have no financial disclosures. So the playbook for this presentation, first of all, we'll go, why do we need an alternative therapy for diabetic macular edema at all? The unmet need, the problem, the magnitude. And how can micropulse laser subthreshold help in DME management, the rationale, which Lite has already covered. So I'll just go past that, fly past that pretty fast. And how should subthreshold micropulse laser be done in DME? Basically the parameters, and this is important. And then how effective has or is micropulse subthreshold laser in DME, the evidence to support, and where can this find a place in DME management, the future role, okay? So with that, we are in the midst of this surging pandemic of diabetes, where, it's been projected that there's going to be a 51% global increase by 2045 from the current 463 million to about 700 million. 40% of the adult population may have diabetic retinopathy, 7% of the diabetic population may have diabetic macular edema. So that's the magnitude of the problem that we are kind of looking at. So the evolution of, management of DME has moved from the erstwhile, laser photocoagulation in the 80s through the turn of millennium where we had steroids coming in, and to this current anti-VEGF era. And, evolution of DME management has moved with the anti-VEGF era, with the advent of that, from preventing visual loss, which was the case with the lasers, to currently through all these trials with anti-VEGF agents to actually gaining equity. Now, a survey of over 100,000 patients from more than 1,700 plus retina specialists showed that the comparative patient compliance for diabetic macular edema was far lesser than neovascular AMD both US and Europe. So this is a major problem. People started recognizing this is a problem. And ASRS in its PATH survey in 2017 found that over 50%, the overwhelming majority of physicians felt that there was the need to reduce treatment burden and highlighted the need for a greater durability of therapy. Also, it was noted by healthcare authorities that there was significantly higher healthcare resource utilization in DME patients compared with non-DME patients. So this is why it is a major problem even for healthcare providers, administrators. So therefore, the unequal need of the hour was to provide therapy or offer therapy which provides maximum sustained equity gains, of course, and those that require fewer injections than the current very repetitive anti-VEGF treatments. And this would benefit patients, physicians, as well as the healthcare systems of countries. Now, refractory DME, we begin to understand, present in a clear and present danger, where all the major trials showed that there was a significant quanta of patients with DME who were refractory to this anti-VEGF therapy. And why is this so? That's because simply the pathogenesis is multifactorial. Though the key driver of diabetes is hyperglycemia, and then by triggering a bunch of biochemical pathways released through different mechanisms, it triggers a number of cytokines and chemokines. Only one out of this, of course, the primary is VEGF. So when you use anti-VEGF drugs exclusively, you're addressing that one primary but only single component. There are almost half a dozen or dozen others which are not being addressed equal, kind of with the same efficacy. And therefore, through these alteration of blood-retinal barriers, increased vascularity, you do have DME. So there is, for this reason, there is some quanta of refractory DME that we have to deal with or face. Now, how can subthreshold micropulse laser help in DME management? The rationale. So with the conventional laser that we had in DME, the indications, and this was a publication we had put out from our IGO group, AIOS group in the IGO, Indian Journal of Ophthalmology, the indications, surviving indications for conventional laser, non-center involving DME, patients with recent stroke or heart attack, or those with a high cardiovascular risk, and therefore where those you might want to avoid intravitreal injections such as bevacizumab, or patients themselves decline a repetitive therapy, or as an adjunct to intravitreal anti-VEGF steroids when DME is not fully responding based on OCT. Now, ETDRS, showed us how efficacious macular photocoagulation was, but it also did recognize its limitations, such as these. And we also kind of recognize that there is an occasional, very rare morbidity with, continuous wave laser, accidental foveal burn, subfoveal fibrosis, central, paracentral scotomas, laser-induced CNVM, rare, but could still happen. Now, comparing continuous, wave laser with micropulse, it has also done that. I'll run past this. This is continuous, that's pulse. It's in milliseconds. Micropulse is in microseconds, as the name suggests. Single pulse laser of 0.1 to 0.5 seconds, delivering a preset laser energy, whereas this is a train of multiple repetitive micropulses within an envelope. And here, in photocoagulation, you have this obvious photocoagulative necrosis of target tissue, this severe damage. Whereas with micropulse laser, there's a modulation of the heat shock proteins expression in the RP, and it regulates, downgrades the cytokine expression. So this is the cartoon which shows, as Lita had also shown, irreversible thermal drainage, because there's a continuous train of that photocoagulative laser, and you can see the heat quanta is massive. On the other hand, when you chop up this strain into these several micropulses, you see there's very small heat aliquots which are being raised at the tissue level, and there's enough time for it to cool. So that's basically it. Then how should micropulse laser be done in DME? So this is the guidelines which we had given. Jay had taken the lead, and this was from our group, and we had put this out. So for DME, so he's mentioned for CSCR, for DME, as we suggest, it should be 5% with the yellow laser. 577 is what we suggest. 200 milliseconds pulse duration, 150 to 200 microns, no spacing between spots, as we are reiterating again and again. Yes, please go ahead and titrate. It should be 50% of the threshold power. So how effective has it been in DME, and what is the evidence looking at backing this up? Oh, I see this. There's something wrong with the font. Anyway, subthreshold micropulse laser versus conventional. Chen gave us this meta-analysis looking at about 400 eyes who received micropulse subthreshold laser as well as conventional, and they found equity gain was significant in patients with micropulse laser compared to continuous wave at 3, 6, 9, and 12 months, and concluded that its micropulse laser was superior to conventional laser in treating DME in in terms of 1 year equity gain. So there was unequivocal evidence here. Now the diamond study by Lois et al. They also looked at this. This was a multi-center study. The previous one was a meta-analysis. And again, they determined clinical effectiveness, safety, cost effectiveness of micropulse was a standard laser for DME with central retinal thickness less than 400 microns. Let me stress that, less than 400 microns. And they looked at about 266 eyes, randomized them 1:1 to 577 versus standard laser. Retreatments were allowed. Rescue treatment was allowed, anti-VEGF or steroid, if equity dropped greater or equal to 10 letters or the macular central foveal thickness increased beyond 400 microns. And they found that there was no significant difference between both groups at the end of 24 months based on equity, CMT reduction. Number of micropulse laser sessions for them were slightly greater than standard laser, and they felt that micropulse laser was almost similar and effective to standard laser, but they did add a rider that majority of patients had poorly controlled diabetes, and therefore they couldn't make a very strong comment about the efficacy. Then Wu et al. Put out this Bayesian pool meta-analysis where they looked at number of therapies, and they concluded that the most effective therapy was ranibizumab and a continuous laser, which is greater than diode micropulse mono, greater than bevacizumab plus continuous laser, which is better than continuous laser mono. So they found the diode micropulse laser was similar to conventional laser. Now, this was very interesting. Klagi et al. Looked at what we really are, kind of trying to gun for. Micropulse laser for refractory DME, the anti-VEGF combo. Where is the place of, micropulse with a combination of anti-VEGF? They picked only refractory DME eyes, 42 eyes, 2 groups, bevacizumab and micropulse diode versus bevacizumab alone. And they looked at, found significant gains, CMT decrease at 3 months in patients receiving the combination. So combining micropulse with anti-VEGF therapy significantly increased the equity outcomes and reduced CMT for refractory DME. So therefore there's definitely a shot in the arm for micropulse with combination. Citric did something equally interesting. They looked at micropulse laser in DME and the impact of the central foveal thickness. So they tried to evaluate the effect of differing central foveal thickness on micropulse laser, yellow laser efficacy in DME. 80 eyes and for the recurrent DME post-ranibizumab divided into 4 groups. 3 of these groups received treatment. So group 1 was 200 to 300 microns, group 2 301 to 400, group 3 greater than 401. Group 4 200 to 300 microns untreated. Okay, so group 1 to 3 essentially were treated with micropulse laser and prospectively evaluated over 6 months. And they found that micropulse laser treated patients with CFT less than 300 microns had the best equity gains and CFT reduction. So there's some information for us there, and conclude that it was most effective in this subset. Now, one of our members of the SOLS Society, Slavoj AIOS2025, looked at DME in biomarkers, okay, and how they affect the OCT octa parameters. And with micropulse, and they looked at all these central macular thickness, hyperreflective spots, drill, microaneurysms, macular perfusion parameters, and they found that micropulse laser reduced the number of HRS, hyperreflective spots, which are, as we know, signs of activated microglia in the retina, MA drill extension, and the area of cysts. So they suggested that perhaps micropulse laser may have an anti-inflammatory effect on DME. Now, Friziero went further and did a systematic review and looked at the effect of micropulse laser on neuroinflammatory biomarkers, and they found that it reduced VEGF, PEDF, GFAP, glial fibrillary acidic protein, and KIR1, and increased EPO. And they also concluded that micropulse alone was safe and effective in mild DME and in combination with intravitreal anti-VEGF, especially in cases of severe or refractory DME. So this is a few experiences. This is a case where the patient has just foveal DME with a bit of intraretinal fluid. You see micropulse laser done, and then repeat it again at 3 months, and then you see a good resolution at 6 parts 6 months down. This is a case with IRF plus a little bit of subretinal fluid, little bit. You can see just a very small amount. Again, micropulse done and repeated at 2 months, 6-12 improving to 6-9, and then at 5 months you see good resolution. Okay, some hard exudates were also there. A third scenario where now you have IRF, subretinal fluid, hard exudates, but it's a little thicker. You can see the fairly significant amount of subretinal fluid. So in this kind of situation, I would prefer going in for ranibizumab, reducing that SRF, then putting in micropulse laser, and you see at 4 months a good outcome. A fourth scenario where again this IRF and subretinal fluid, again fairly significant subretinal fluid with hard exudates. Here I'm doing sequential therapy, micropulse laser, and then 2 days later, just 2 days later, anti-VEGF treatment, and then at 2 months repeating the micropulse, and again you see a good outcome. So these are ways in which you can combine and micropulse, or even have it as standalone. So this was a short little study which we just concluded. One of our PGs, postgraduates, doing a thesis. We looked at studying the efficacy and safety of adding micropulse laser prior to injecting ranibizumab in patients with center involving diabetic macular edema. We looked at assessing the CMT and best corrected acuity in patients receiving additional micropulse with ranibizumab versus patients receiving ranibizumab monotherapy, and compared the cumulative injections required to treat DME in each group. This was a study designed, prospective, randomized in our department over a year, and the inclusion criteria 6'9" to 3/60 patients over age 18. Quickly follow up. So basically group 1 was the combination, group 2 was ranibizumab alone, and this was how it was. We retreated if it was persistent with ranibizumab at the first follow-up a month, and then at the second follow-up we added, if there was persistent, we added ranibizumab in that group A arm, whereas the other ones where if it was persistent, we added anti-VEGF. We just treated with anti-VEGF only, ranibizumab. And this is what we found, that 44% were randomized to 2 treatment arms, group A the combination, group B only ranibizumab. Demographic parameters were almost all the same, and what they showed is both groups showed significant improvement in acuity as well as reduction in central macular thickness from baseline to final visit. And group A, although group A had greater reduction, the combination in CMT from baseline till final visit than group B, difference was not statistically significant, though you see that the trend was a little greater in the combination arm. Whereas in patients in group A received more injections, less injections, 24 injections up to final visit. Group B, the ranibizumab monotherapy, had much more injections, and so there was a benefit in terms of reducing the number of repetitive treatments. And patients in group A, the patients with subretinal fluid, we found this was interesting, had a better resolution and improvement in acuity after treatment with the combination compared to eyes with intraretinal fluid only. Again, something interesting to note. So this was the data. And finally, where can we place subthreshold micropulse laser in the management of DME? So this is just one final slide. So if anti-VEGF is contraindicated or there are compliance issues, immediately micropulse laser comes into play. Okay, that's straightforward. Non-center involving DME, again, it has significant potential. You could reduce anti-VEGF injections, so there's no controversy there again. Okay, otherwise you would treat it with focal ablative. Instead of that, you can treat with micropulse laser. Now, as we've seen in the previous studies, 300 microns was kind of a watershed. So if it is less than 300 microns, or there's minimal or no subretinal fluid, as I've shown in some of the cases, you could use, and I'm not saying that you should use, I'm saying you could use standalone micropulse laser, okay, especially if there are contraindications. If there is significant subretinal fluid, we still feel that anti-VEGF would be a good idea, and then following up with a combination of micropulse subthreshold laser. If it is between 300 to 400, you could consider repetitive micropulse yellow laser, as I've shown in some cases, with or without anti-VEGF rescue. I think that's important to stress, that anti-VEGF rescue may be required, or you could use it as combination or sequential treatment. If it's more than 400 microns, perhaps it's a better idea to use anti-VEGF followed with combination micropulse laser. Thank you. Yeah, any questions?
Anand, can I ask you a question?
Oh, yeah, of course. All right.
I was wondering, like Lite was mentioning that he usually waits for 6 to 8 weeks and then repeats the laser for CSC. So in DME, if you are treating somebody primarily with subthreshold laser, how long do you wait? And is there a like, do you believe that, do you want to supplement anti-VEGF in between? How do you make the next few months planning when you're treating
Can I just have that slide again? I can just, illustrate that better with this thing. So, like I said, if it's less than 300 and it's showing a trend towards improvement, then I might, and if the patient is more or less static, I might have a conversation with the patient and repeat it at, I would not do it at 4 weeks, probably 6 to 8 weeks is when I think that would be a good this thing. And if I'm seeing a fairly fair improvement in the parameters, also, systemic, because diabetes is different, DME is different from CSCR in that there's so much of influence of your systemic parameters, on that. If the patient's DME, it's something like 8, 9 or something, I might be a little more patient. There's a downtrend. But at the same time, let me, so this is it. So if it's less than 300, I'm more interested in being proactive, or around 300 to 400, more proactive with repetitive micropulse. Especially in our population, patients are more hesitant to get injections because everything is coming out of the pocket more or less. So that's also an important consideration in India and other Southeast Asia. I think that's important. And so there I'm a little more proactive. On the other hand, if there is an increasing trend, if the fluid is increasing, IRF or SRF is increasing beyond 400 microns, then I would be more proactive in suggesting anti-VEGF as a injection. I would probably do micropulse and anti-VEGF, or just anti-VEGF. So that's what I suggested in the last line. Yeah.
Thank you. Yeah.
You already raised the issue of systemic parameters.
Yes.
So, what was that in these patients? And did you try to analyze whether
so
they were going to have a better control, metabolic control, better renal parameters? By the time you start treating them, we always advise metabolic control and checkup of the renal conditions, and then trying to get their glomerular filtration rates better and all that.
Yeah.
Improved rather.
Yes, so these were not patients who are very severe, like on dialysis, or we excluded those patients with dialysis or very heavy, high blood pressure or very severe recent cardiac events. Sick patients, I'm talking of that little study of ours. So we had a large list of exclusion criteria also. Yeah, so we did. But otherwise, both the groups were comparable for all the other parameters. It's the same demographically. Yeah. Okay, thank you.
So the next speaker is going to be Jay Shablani, Endorsed Society Guidelines for Subthreshold Laser. Jay.
Hello, everybody. I'll be presenting our society guidelines, that is SOLS, Subthreshold Laser Society, Subthreshold Laser Ophthalmic Society. These are my financial disclosure. I am a consultant for ODOS, which makes microsecond laser, which is also a subthreshold laser. This is the guidelines which we published a couple of years ago in journal I. I'll quickly take you through these guidelines, but before we really reach to the guidelines, it is important that why do we really need guidelines for subthreshold laser? Because subthreshold laser has been here for more than 4 decades, because people were doing subthreshold laser almost 30 years ago. And I would say that, in spite of having numerous randomized controlled trials, real life studies, which have really brought this laser in the picture, like we heard from previous speakers, but unfortunately all these studies have a lot of variability in terms of the parameters, including laser, the thresholding weight, the titration part, the duration, and the spacing. So in spite of having so much data on subthreshold laser, we did not have any standard protocols. So that's why we are still in dilemma that whether this laser works or not, and what is the best way to deliver the laser. So what we did was we started a study to establish the guidelines for subthreshold laser among SOLS members. For this, we chose 12 experts who had more than 5 years of experience with subthreshold laser. We prepared 43 questions. In the first round, we got the responses in the masked manner. Then we organized 2 virtual meetings, and then we established the guidelines. And which guidelines I'm going to share with you, they are pretty independent of any specific laser device. And I can tell you that in SOLS group, the best part what I like is that we are beyond any industry or beyond any specific laser, because I work a lot with Nevilas, Lide works with Lumibird, and we have people who are working with Quantel. So it is actually putting all these things together and moving this subthreshold laser per se, and that was the whole purpose. So what we propose is that for diabetic macular edema, you can perform subthreshold laser for both center as well as non-center involving macular edema, with or without any conjunction with anti-VEGF therapy. We advise 5% duty cycle with 200 millisecond pulse duration with 150 to 200 micron spot size, with no spacing between laser spots, using integrated pattern system. Each word has been really gone through a lot of discussion. When I say the second point, that remember we are using a 5% duty cycle, and we are actually not using any spacing, and we are using a pattern. So like Lita mentioned earlier, so we are assuring that when we say that there is no spacing, the pattern is assuring that the laser is done without any spacing, because it is impossible to do 891 in that fashion. We propose titration with 50% of threshold power, and you guys will be surprised that I'm standing here in 25 and saying this line so easily, but we have gone through this 50% threshold for almost 4 or 5 years. Means when I started doing subthreshold laser in 2009, 10, and I used to do first laser, first do threshold power with continuous wave, then cut it to 30%, and there were like a lot of discussion around it, then rapid experiments. Then he finally came to the consensus that let's titrate with the subthreshold laser and then cut it half. You can perform the laser on the edematous area with subthreshold laser. However, it does not mandate any focal treatment of microaneurysm. Again, there is a difference compared to the continuous wave laser. We are not advising any specific focal treatment to the microaneurysm, because we believe the laser energy being delivered to the RPE is sufficient to actually help you to absorb this. Moving further into diabetic macular edema, the transfoveal treatment, like we discussed earlier, is treatment safe. We do not recommend any specific structural imaging studies, but if you want to sleep well, you are just starting, it is okay to get it done to make sure that you are not fried the fovea. So it's better that in the beginning do autofluorescence or OCT, document there is no structural damage, but we don't recommend that. We recommend to follow up in 6 to 8 weeks after subthreshold laser. However, repeat subthreshold laser is suggested after 2 to 3 months of initial application in case of poor response. I understand that this line has a lot of gray area, because like Anand beautifully showed you multiple ways and the timing of the subthreshold laser with or without anti-VEGF therapy. But I think that DME is one of the very complex disease. So don't take this point, the third point, verbatim that I have to wait. But yeah, if your systemic control is good, you can wait. If it is not good, then you need to talk to the patient. We recommend anti-VEGF, conjunctive anti-VEGF for steroid therapy as per the physician discretion, because again, DME is very subjective. You definitely have to work with the patient. I don't think that even with anti-VEGF monotherapy, we have a blinded approach. We always work with the patient and figure out when to change OCT structures and many things. So we are not able to really give you computerized ways of deciding subthreshold laser, but these are guidelines to support you. Talking about CSCR, we spoke a lot about it. We offer subthreshold laser for both acute as well as chronic types of laser. Acute CSCR, because it is so safe, then why to wait for 4 months? If a patient has acute CSCR, give a month. If there is no resolution, you can do the laser even at month 1. So for chronic CSCR, we definitely support this as first line as well as in the combination therapy. Again, CSC is also a very complex disease, because many times we have to put the patient on eplerenone. We have to do also, do yoga, stress therapy. So there is like a lot of pieces go in treating the chronic CSC. So when we are treating CSC, we are advising the same thing: 5% duty cycle with 200 millisecond pulse duration, 100 to 200 micron spot size, titration with 50%, and continuous, or I should say no spacing laser. Settings are pretty much same for both acute and chronic CSC. Transfoveal is safe, like we discussed earlier. For acute CSC, we are doing laser to the focal leak as well as to the adjacent area, because by now we understand that it is not just the leak area, but actually the choroidal structure surrounding area is also contributing. So for chronic CSC, we like to do both focal as well as diffuse hyperfluorescence areas on fluorescein angiography, just to make it a little simpler. One of the questions for Lite was that, yeah, there was a lot of leaky spots which we suspect on hyperfluorescence. So here we are advising treatment to actually the sick RPE. That's why you have to do a much larger area in CSR with a lot of complex RP damage. You can get autofluorescence or OCT just to document how the structural changes are, but you have to understand that the primary pathology is also contributing to these changes. So evaluation is in 6 to 8 weeks. If in case of poor response, we can repeat. And like I mentioned earlier, that the structural safety is so much that you can repeat micropulse laser. I have done micropulse laser for many patients 4 or 5 times in a year. This is just a summary. This is the table which Anand also showed. With this, I would conclude that these consensus guidelines do not suggest management of these disease, because trust me, among ourselves, we were like, okay, so we are not managing the disease for you. We are just advising the guidelines for the laser. So you have to definitely plan for individual patient, not to treat the disease, but to actually, these are just guidelines. To establish standard subthreshold laser application, because we really feel that once the whole community starts using a standard application of these laser, where we have standardized the protocol, that will give us the opportunity to understand whether how this randomized controlled trial globally will be used, which ethnic group is responding how, which disease stage will matter. So I think we are still far from level 1 evidence, but this is really a one step towards creating a level 1 evidence. So if you guys are interested, go through this paper, and thank you so much for your attention.
Thank you, Jay. An excellent talk. I think he's kind of made it absolutely clear as to our guidelines and our philosophy going forwards along with the science. So does anybody have any questions further regarding that? Yeah, please. Can you use the mic, please?
Are these guidelines also for the green lasers or only for yellow?
Very good question. Yes, they are for both. They are for both. But in our experience, we have realized that now most of the devices are moving towards 577, right? I think everybody is moving to 577, so we will eventually we'll have 577. However, definitely not apply these on 891, and that is one of the concerns we have about the place trial, is that 891 you cannot see the spot, but you don't know what you're doing. But here, we are using the pattern. Here we are standardizing the protocol. So here we are titrating. So we know that what we are doing has some, when you step back and think, you will realize that, yeah, there is some sense to it. With 891, I still have challenge in understanding, what to expect.
So I like to make a comment sometimes. So one of the questions that I get is that if there's more edema, do you need to compensate for that? And the answer is no, because we're not treating that. The target's still the RPE, so just stick to the guidelines. And when we do the titration, it's in normal retina outside the arcade, so we're not,
Could you use the mic, please?
Can you take the mic, please?
Can you repeat the question?
How many spot burn in the one sickle for the CS or something like that?
So we are
spot burn, not spot sign, the power, something like that. How many spot burn?
No, that entirely depends. He's asking how many spot burns in one treatment sitting. So
Oh,
it entirely
that-
depends on the
Oh,
amount
that's
of
okay.
edema
Because
and
one
amount of
time
area.
I do for the CSCs all very good result, but maybe 60 spot burn. After 2 weeks, they have the chronic CSCs all, yeah. When it come
Please keep your mic.
1 year back to me, he sent sick in 60, but I do the laser after 2 weeks, 6 and 9. So, but the spot burn, maybe I don't know because I never see, but I do maybe 60 spot burn, maybe more, yeah.
Yeah,
More.
so there's absolutely, see, as long as you're treating contiguously, as everybody has, kind of reiterated, it does not matter as to how many spots you have put in the macula. So as long as you're going again and you're not over retreating that same area in the same sitting. If you're going clean across in an organized way as the pattern laser helps you do, then it doesn't matter. It all depends, you may have edema this much, some other patient you may have this much, you may be treating bilaterally, one eye may be this much, one eye may be that much. So the number doesn't matter.
Okay,
Alright,
thank you.
I have another question. Do you have any experience in using subthreshold laser in cases like persistent edema in in BRVO, for example? Other cases? Thank you.
Sure. I don't know if Martin's going to talk about that, but yes, I have done that and I've found a beneficial effect. Of course, we don't have a randomized control trial to look at that, but yes, I think it can benefit. Yeah. Good question. So, yeah. It's my pleasure now to invite Dr. Martin Brelin from Hong Kong to talk to us about case studies, yeah, and blow some myths. Right?
Yes.
Yeah.
Yes, we've got a two-part talk. We're going to look at some cases, and we are also going to dispel some myths.
Dr. Martin's talk up, please. Is it on this one? So while they bring Dr. Martin's talk up, we are inviting and encouraging people to participate and become members of our SOLS society. And I'll give you our email ID at the end of this, and you can write in, and we'll have a process. Okay? Yeah. Yep.
Yes, there we are. Wonderful. It's not coming up on here. Do you want me on the other side? Okay, right. I will.
No, there is not. It's not coming here as well. Okay, I think I can start it. Like, it seems I have to start it here. Oh, it says it cannot be launched. I got it.
It's up on the screen, so
Yes, I got it.
let's give it a go on this one. Okay, great. Thanks again for the opportunity to present today. We're going to look at some cases and, as we mentioned, resolve some of these myths and misconceptions. I have no relevant financial disclosures. We talked this afternoon about a number of conditions that can be treated with micropulse laser. I'll be focusing once again mainly on CSR. Anand gave a beautiful talk on diabetic macular edema. There was a question earlier about retinal vein occlusions. I'll confess myself, I've never tried it in an RVO. And there's even talk about using micropulse after retinal detachment surgery where there's persistent subretinal fluid. And I know Barbara has mentioned this before, Barbara Parolini. My experience comes predominantly from, as Lite mentioned, a clinical trial that we published last year, a prospective RCT comparing half-dose PDT with micropulse. And this was a fairly comprehensive study. We followed the patients up at very frequent intervals and followed them for a whole year with resolution of subretinal fluid being the primary endpoint. And at each visit, we did really comprehensive investigations of the patients. So we've got really good imaging data showing the course of events that happens after micropulse laser treatment. I won't persevere on this point, but titration, making sure you've got the right spot size and the spot density, and following the guidelines from SOLS is absolutely critical in order to get good treatment results. I think myself, and this is just my own anecdotal feeling, is that when you treat with micropulse in CSR cases, you either get patients that just need a single treatment and then they go dry and then they're fine. You get a few that have a recurrence and then they have a repeat treatment and they go dry. And a very small group have a persistence that requires you to be a little bit more perseverant with the treatment. So let me give you some of these cases. So again, my cases are all chronic or recurrent CSR cases. So the patients are a little bit older. This is a male, 54 years old, right eye CSR with a vision of 20/30 with blurring and metamorphopsia for 3 months. And you can tell it's chronic because you can see on the autofluorescence that the RPE is really quite sick. And on the fluorescein, you can see the main area of leakage just above the fovea. And to answer the lady's question from earlier, all these patients had fluorescein and ICG at baseline and before any retreatment. Here's the fluid, 426 micrometers central subfoveal thickness. Here's the spot size if you were interested to do PDT. All these cases had micropulse. And you can see with just a single treatment in October of 2019, some 4 weeks later, the retina is completely dry, and the vision has now improved to 20/25. The retina remained dry until the final end point of the study, which was 1 year, and in October, when the vision had further improved to 2018. So this, I have to say, is the overriding majority of cases that I had in my micropulse treatment group. This case is a little bit different. First of all, a bit unusual because it's a female, but presented, and also a hyperope, which is really unusual for Hong Kong, but presented with reduced vision for 6 months in the left eye with a vision of 20/25. This was probably not a chronic or recurrent case because, as you can see, the autofluorescence looks pretty good, and you get a single ink blot leakage on the fluorescein. The fluid was 422 central subfoveal thickness, and you can see quite clearly the correlation between the fluorescein and the leakage spot causing the fluid accumulation on the OCT. Here's the spot size on ICG if we were doing PDT, but this lady received micropulse in October of 2019, and then some 6 weeks later, vision had improved to 20/20 and the retina was dry. We were very happy, but then unfortunately some 3 months later there was a small recurrence. You can see a little bit of fluid, and the same area of leakage has a recurrence on the fluorescein angiogram, and the vision dropped back down to 20/25. No big deal, we just simply repeat the treatment, and as the speakers have alluded to this afternoon, you can repeat the treatment many times over without much concern. So a further treatment was done with micropulse, and then some 6 weeks later, the retina is dry again with a vision of 20/20 until the end point of the visit, when the retina remained dry and vision was 20/20. Here's a more typical scenario of a young male with 20/18 vision, both eyes, but complaining of a scotoma for 9 months in the left eye. You can tell that this is also chronic just from the fundus photo. You can see some RPE change in drusen. And on the fluorescein, interestingly, the site of leakage here is quite close to the disc. And again, this is worth debating, you know, that if you were to PDT this, it would be perilously close to the disc and may not even be reachable, given that you have to be 500 micrometers away from the disc to do the PDT. Whereas with micropulse, you simply treat the whole area where the fluid is. So that's exactly what we did for this case. Here's the OCT at baseline. Here's the spot size, which has been displaced to the right because we need to be a little distance away from the disc. And the vision improved even further. So presented with 20/18, but became 20/16 at 6 weeks after the first laser treatment. There was a small recurrence once again a couple of months later. Again, the same area was leaking, and a further micropulse laser was done, and the retina remained dry for the duration of the future visits, with an end result of 20/20 unaided and a dry macula. So on to the second part of my talk, which is to try and dispel some of the common myths that I hear about micropulse laser. And these are not quotes that I've generated out of thin air. This is approximately 10 to 11 years of experience with using micropulse. These are actual comments that have been made by my colleagues working in the same department, okay? So these are genuine things that we have to deal with on a daily basis when we're trying to convince doctors that use a lot of PDT that they should be switching to micropulse. So myth number one is I don't want to use micropulse because the visual acuity gain is likely to be better with photodynamic therapy. That one we can dispel because we now have our randomized controlled clinical trial on CSR comparing PDT with micropulse laser, and we see equivalent visual acuity gains in both treatment groups. There is no statistically significant difference at any visit for an entire 1 year duration of follow-up, and both groups had, as you can see at the bottom of the slide, a statistically significant improvement from baseline regardless of which treatment. So we can dispel myth number one that you get better outcomes with one type of treatment compared to the other. Myth number two, I don't want to use micropulse because the drying effect of photodynamic therapy is better. And I should stress this point because this was one of the outcomes from our publication last year. Unfortunately, it's been slightly amplified since the publication, and I want to put the record straight here, which is that the drying effect, and here you can see the central subfoveal thickness on OCT in the micropulse versus the half-dose groups are equivalent. The drying effect is no statistically significant difference at any time point, and there is a significant improvement in both. Where there's a bit of controversy is that the drying effect was marginally faster in the PDT group. But I would argue that the difference was so small that it's clinically not relevant. And it was not statistically significant at any time point. There is a small difference in the Kaplan-Meier plot, which I haven't got here for you now, but you can have a look at in my publication, that the drying effect at 3 months was marginally faster. But by 6 months, there is no difference once more in the two treatment arms. So I don't think there is much difference here between the drying effect of the two treatments. Myth number three that I've heard a lot, I don't want to use micropulse because I hear it damages the RPE. I think we've dispelled that one already because the basic science has been demonstrated already to show that there's no damaging effect to the RPE. I guess what I can add is that for all of our patients at every visit, we performed microperimetry. So we have really good longitudinal data on retinal sensitivity using microperimetry. There is a good improvement in retinal sensitivity in both treatment groups, and again, no statistical significant difference at any time point between the two treatment arms. Here's just an example of the microperimetry results showing the improvement in retinal sensitivity after micropulse laser, for example. Here's another thing I hear, which is I don't want to use micropulse because I've heard that the recurrence rate is much higher if I use micropulse than if I use PDT. And I think the argument here that some doctors use is that because PDT performs this choroidal vascular remodeling, as they call it, I just call it burning the choroid. The choroidal vascular index and the choroidal thickness is reduced after PDT, which is not in micropulse. And people extrapolate that result to suggest that because the choroid is still thickened and because there's still pachychoroidal features, there must be a higher recurrence. We've actually now, and this is hot off the press, we called back all of the patients from our clinical trial in a retrospective manner, asked them about what happened 1 year after they exited the study. And we've, spoiler alert here because this is now being reviewed and will shortly be published, hopefully. There was no statistically significant difference in the recurrence rate between the two treatment arms. So the recurrence is there in both treatments, and there's no difference between the two groups. And the last one is I don't want to use micropulse because patient satisfaction must be better with PDT. And actually it's the reverse result that we found in our study. When you looked at the visual function questionnaires, it actually scored higher in the micropulse group than it did with PDT. And interestingly, this was also found in the PLACE clinical trial. So for all its flaws, it actually found the same result as us, which is that patient satisfaction is slightly higher with micropulse. So in summary, in Hong Kong and in my department, we are switching most, if not all, of our CSR cases over to micropulse now. We have, just like everyone else, a supply chain shortage of verteporfin. Verteporfin is a self-financed item in Hong Kong. It's extremely expensive for the patients to use. We like to use micropulse just even from the setup of the clinic point of view, because we don't need to put in infusion lines, get the infusion running of verteporfin, wait 15 minutes and then do laser. We just simply take the patient to the laser room, do the laser and then send them home. And we also don't need to give them lots of worrying things like don't expose yourself to sunlight afterwards, wear dark glasses and cover your skin. It's just like any other laser, so it's just infinitely more convenient to perform. So with that, I thank you all for your time and attention, and I welcome you all to Hong Kong next year for APAO 2026. Thank you.
Do we have any questions for Martin?
I have a follow-up questions about the RVO. So which parameter do you use for RVO case? The CSR or the DMA one?
Yeah, I prefer to use the DME parameters. Yeah, because it's a edema, similar to DME. So it's that. And I'd just like to touch upon that last thing. We were both lit, and we were surprised that people felt that the happiness quotient was more with PDT, considering that with PDT you have to be fully covered and wear a cap and have a Venflon and have an injection inside. Whereas with micropulse, it's walk in, walk out. It's just a 10-minute job. So I'm surprised people would think that patients would be happier with PDT. So much more difficult, so much more expensive.
But I think also adding to this is a sort of stubborn mindset that I notice, particularly in the area where I work, where PDT has been the gold standard for so long, and unfortunately what happens is that times don't really move on with the training as well. So even when the residents of yesteryear now become consultants, they're still teaching the residents that PDT is the only treatment available because they've never even tried the micropulse, even though we have really good clinical trial data on the local cohort population to show that this works really well. So changing mindset of, dare I say, some of the more senior retina specialists is really difficult, and they're very reluctant to try new things.
Other thing we didn't really touch upon here was also the use of eplerenone for CSCR, especially where you have diffuse RP damage. So a lot of people have been doing that, and that came into vogue or surfaced a little more when PDT was, on its way out of Visadigm, was going off. But then, the issues with hyperkalemia and having to continuously monitor the potassium levels and the patients at risk. Some of these patients with a lot of diffuse RP damage, unfortunately, are also cardiac patients. So you're taking a risk. You're putting something into the body, and there's a systemic ramifications for that. So that's another aspect. So therefore, micropulse as a local treatment you don't need to do all that. So from that point also, it's far safer. Yeah, Jay, you want to add something? Yeah.
I'd like to make a comment also. If you remember from the AMD days that we used to do PDT, remember that around 4% of patients that underwent PDT had severe visual loss. And I think that the trials, the PLACE, Martin's trials, didn't show that because just the numbers were probably too small. But if you do it long enough, maybe you can get that as well.
So yes, I think we are done. Thank you for staying this late and bearing with us. And I hope to see more people with taking in. Yes. Yeah. So I was coming to that. So we have this society, and I'm going to leave this email ID here for all those who would like to write in and express interest in joining. For now, we are keeping the membership free. So please feel free, and you will have a 1-point or 2-point authentication system. So it's right here. So can I ask all I'd like to thank Dr. Lithe, who's come from very far here, Jay and Martin, for being part of this instruction course, and we hope to continue doing this in the APOs in future as well as the All India conferences. So hope to see more users in the days to come. Thank you. Can we have a picture with with all the panelists.